Our theme addresses the challenges of children that are born with a congenital anomalies, or they have the consequence of having a tissue damage, and they need that to be repaired or restored using innovative and challenging treatment. Yeah, malformation like this can be affecting the entire life of these children, and sometimes are associated to mortality. Moreover, there's about 6% of all newborn that are affected by those malformations and require innovative and challenging surgery to be treated. Together with our partners, we are world leading on the research and treatment of those congenital malformations that may be affecting the brain, the heart, the kidney, the skull, and the face. So we provide in the hospital a highly specialized commission service that deliver, for example, the first tissue engineering trachea to patient, that has delivered the largest number of conjoined twin separation, and has done for the first time a repair of spina bifida in utero, so to repair the defect before the baby is even born. Yeah, our vision is to really improve the expectancy and quality of life of these children, for example, using tissue engineering technology. And we can do that using three approaches. One is to build in vitro organoids, so small organs, if you wish, that could mimic what happened in the body. And so we could test new drug, new therapeutic approach in vitro before delivering into patient. The second approach is to build those organs using the same technology to substitute the one that doesn't work in children, that do not work in children. And the third is to use a new device and new technology to build devices that could help children to get better without having to replace their organs.
Thank you. And it's my great pleasure to pass on to Professor Silvia Schivano and Paolo De Coppi for a really fantastic, futuristic presentation.
No expectation there. I can assure you I have normal clothes somewhere just after the video. So my name is Paolo De Coppi, and I'm very fortunate to co-lead this team with Professor Jane Soden, that is here in the audience. It gives me a great pleasure today to show you some of the and to share the presentation today with Professor Schivano, who is one of the leaders on engineering here in the Institute, and really help us moving the field forward. So if I, thank you. So the strategy of our team really go all the way through from the in vitro modeling, as you heard just before, of organs to organ development, and then try to use some of the devices and surgical sciences development that we have in the Institute, and taking advantage of those collaborations to move forwards into patient. And so in many occasions, as clearly explained by Thomas, we can go from proof of concept to the preclinical and then the first in child. And so I want to show you here some of those development that are happening in the theme. And that's really the end of the game, is to ameliorate the future of surgery and the surgery that we do in the children at GOSH and beyond GOSH. And we do this through partnership, and in particular in the theme we're working closely with Alda Hay Children's Hospital. And so those technology at the end led us to benefit for children and fetus, as for this example here. So one of the examples that I want to show you is spina bifida repair. So spina bifida, for many of you, it doesn't come as a surprise as a topic. It's a neural tube defect, and it's essentially the failure of spine or spinal cord to close and to fuse. And in this scenario, we were the first to introduce this technique to close this defect in the fetus in 2018 as an open closure of the defect, so exposing the utero of moms at about 25 weeks of gestation and closing the defect directly by seeing. In this, for this, we got the BMJ award, and it's really a collaboration between GOSH, many team at GOSH, and I would like to really recognize the leadership of Dominic Thompson among the neurosurgeons and UCLH. And we move towards a more minimal invasive approach. So with training, as you can see here, in vitro training, we could move to do the first case, and we've done now 8 cases inpatient, in which, again, through a collaboration with the obstetrics and the neurosurgeon, we could really close the defect without open the uterus. So with just the camera and the instrument put through the uterus. But what I want to show here with Professor Schivano is something that, again, is a rare condition in which we think we have done a really milestone on treating those conjoined twins. So conjoined twins is when 2 babies are born physically connected to each other. The incidence is very low. There's a rather bit more prevalence in female. And this you see in pictures here are the most famous twin that give the name to Siamese twin, because they were born in Siam, so the Taiwan now, and then they moved to America. So these 2 twins stay together until they were 63. They were really joined by a bit of tissue in the middle. They got married and had with 2 sisters. They had one 11 children and the other one 12 children. I'll leave the rest to imagination. And but they didn't need to be separated. Well, this is not the case for many twin that we get to see. And Great Ormond Street Hospital has the largest experience in conjoined twins in the world. And we have been involved with 41 sets of conjoined twins. However, surgery is not easy, because most of the time we get to not know what we are separating, essentially. And so despite the development of imaging, we get to a situation where we are separating the twins, and there's some surprises there. And most importantly, also, we get a large defect there between the 2 twins that we need to repair. So we are left usually with this type of images, which are very difficult to interpret. So when we go to surgery, we need sort of transfer those images to the baby. And I leave you to Silvia to explain what can happen and what has happened at GOSH.
Thank you, Paolo. So with this situation, Paolo reached out to us, and I work in the Center for Clinical Cardiovascular Engineering. Sorry, just slowly. Yeah, and the video will start. Yeah, I'll start them myself, that's fine. Okay, so Paolo reached to the Clinical Cardiovascular Engineering team that works at Great Ormond Street Hospital and UCL Institute of Cardiovascular Science, because in the past 4 years, we have developed in-house these applications for a virtual reality environment, where it's possible to visualize the anatomy of the patients that are reconstructed from images, and it's possible to have a better understanding of the structures, the relationship between the different organs, and possibly to really understand the morphology and the complex surgeries that can be planned with this. And indeed, we use this type of technology in cardiovascular to help and support the decision process for complex congenital heart diseases, but also in terms of training and education. We developed this app with the professor of cardiac morphology at Roche at UCL Institute of Child Health and Cardiovascular Science, and to really deliver the understanding of cardiac morphology to classes of undergraduate students, master students, especially during COVID, where they did not have access anymore to the lab where they have the specimens they can analyze themselves. So within this app, clearly was developed through the cardiovascular group, but in reality, any kind of anatomies can be imported and studied. And that's what happened with the set of conjoined twins that Paolo was describing. Sure this starts. Yes. So using conventional diagnostic imaging like CT or MRIs, it's possible to further process the 2D stacks of images that usually clinicians work with and create a full anatomical representations of the two twins. Not only it's possible to do it from individual CT sequences or MRI sequences, but it's also possible to combine information from different image modalities and from different sequences. For example, when there is contrast to the arterial or the venous system, and in these complex cases, the contrast being delivered through either one twin or the other twin. And all these can be post-processed and created in one unique environment, where it's possible to explore then the anatomy of the two twins together with the best spatial resolution possible for the two sets of twins. So we imported and processed the images of the two sets of twins that Paolo needed to separate, and we took the entire system into theater the morning of the surgery. This is the viewing room in Theater 10, and you can see basically the full team of different surgeons, experts, nurses, all the people around working together in trying and understanding the surgery. And in particular here, you can see that actually, without sound. Sorry. This is not very relevant, you can just follow this one. It's possible for different users to be in the same virtual environment to study together and understand and analyze the different structures of the two twins together. But it's also possible through connections to project what the users are actually seeing inside the virtual environment for everybody else in the same room, basically, to understand what's the plan. And this is particularly important when you have these type of complex surgeries that involve several different specialties, several different people on the ground, the TSA people, the anesthetists, the surgeons themselves at different levels. So this type of environment allows everybody to be on the same page, so everybody to communicate and have full pictures and understanding without necessarily requiring complex reconstruction in everybody's head of what will happen. So everybody is fully aware of the plan for the separation of these complex cases. Final couple of points. This is an incredible technology that really allows to enhance communications and potentially planning also at the distance. This is a different case of conjoined twins. They are joined by the head, actually, and maybe some of you will recognize the environment is at CR, where we are based. So we are in the office with the neurosurgeon from Great Ormond Street Hospital, but in the virtual environment, the surgeon is actually discussing a complex case of conjoined twins, craniopopus twins, with a group from Rio de Janeiro, so in Brazil, to decide the best planning for this set of twins that needed to be separated. So without having the surgeon to fly or to try via complex exchanges of emails and information, so really to have everybody on the same virtual environment room and try to plan together the surgery. That clearly did not happen in virtual reality, like the newspaper reported. Then the surgeon, a few months later, flew to Brazil and actually supported the team there to do the separation. But this was just a tool to really support the planning phase of the separation. And then one final point relating to communications. The next plan is really to try and include simulations. So try to predict what the surgery will look like for these complex cases. And this is just one example where we use springs to open up the skull of patients that are born with some synostosis to the skull. And we are using this technology to show to the parents of the baby that will need this sort of invasive operations, to make them understand fully what the operation will entail. Again, there is the surgeon that explains to the parents where the springs, so the devices will be placed, what the cut will look like, and above all, what will be the head shape after the surgery, without having to really just to rely on drawers or medical pictures that are really difficult for the parents to understand. So there is huge potential for this type of technology to enhance communications in terms of clinical decision-making process, in terms of supporting planning, but also for education, training, communications, patient and public involvement, and in general, engagement with the public. And this is it, I think, although it's not working anymore. Somebody is moving the slides here. I don't know. This is going. Yeah, now you're on again. Yeah, so that's it. Thank you very much. Thanks a lot.
Now, if there are any questions in the room? There are no questions on Slido this time. No, then if not, thank you so much for your talk.
Thank you.
And